Again, if you can see my pointer, there's in this subpleural area, there's very, very diseased lung with fibrosis and cystic abnormality. And then you can see the transition to much more healthy lung with very delicate alveolar walls and almost normal appearing lung in some regions. If you go in on higher power, you will see those fibroblastic foci. That's where the arrow is. And that is, again, a feature of UIP in typical scenarios. And now NSIP on imaging would be distinguished by the fact that you could see upper and lower lobe involvement. There's much more ground glass, not necessarily a subpleural distribution. And although you could see honeycombing, you could see bronchiectasis, that would be less of a feature in NSIP. And the pathology of NSIP, again, is very different. It's much more heterogeneous. There's involvement of the interlobular septae across the entire specimen. And there could be both cellular and fibrotic changes on these biopsies. But you can see here, there's really not a lot of well-preserved lung on this specimen in distinction to IPF. I mentioned acute exacerbations of ILD. I wanted to mention this again. Any ILD is susceptible to the development of an acute exacerbation. Now, whereas the chronic disease develops over years, and again is the result of the impaired healing of the lung after an injury, the development of acute exacerbation happens more quickly over a period of weeks. And in that setting, you would see neutrophil predominant cellular infiltrate and the development of hyaline membranes, which is the correlate of diffuse alveolar damage on pathology. You may see edema of the airway walls, and this would lead to ground glass on imaging and a very acute clinical change. So to diagnose an acute exacerbation, again, there needs to be a duration that's shorter, typically less than 1 month, without a clear explanation other than acute exacerbation, and with the development of bilateral ground glass infiltrates or consolidations in the absence of volume overload that might explain that. If all of those features are found, you can be fairly confident in the diagnosis of an acute exacerbation that's either triggered by a known injury or not untriggered. And here's some examples of imaging and pathology for acute exacerbations. Again, you can see that it's the lower lobe that's involved, but there's more ground glass involvement than typically seen with IPF. And in the pathology slide, you can see that there's hyaline membrane development. That's that dark pink area that's very homogeneous. And that would be the correlate of diffuse alveolar damage. All right, and finally, to get to the therapy area in IPF. So for many, many years, for decades, as a matter of fact, there were numerous trials that were conducted looking at various potential therapies with promising results that unfortunately ultimately ended up leaving us very disconcerted because they actually did not work. And here's a list of some of those. But in the more recent past, we've been able to A, demonstrate what does not work clearly, and B, develop some new effective therapies, which is very exciting. I do want to review the Panther study just briefly, because this is a lesson in some of the mistakes that we've made in the past. So this was a 3-armed randomized trial looking at patients who received either placebo, NAC alone, which is an antioxidant, or NAC in combination with prednisone and azathioprine. And what they found was that the triple therapy arm actually had to close early because of a significant increase in mortality and hospitalization. And that suggested to us that immune suppression was not only not helpful, but potentially detrimental. And again, in the NAC arm, there was no difference in terms of outcome versus placebo. So that demonstrated that also was not harmful, but was not beneficial. And here you can see in Panther that there was really no benefit to NAC in terms of any of the primary outcomes that they were looking at. At the same time that that study was being finished, there were 2 areas of research that led to significant advances in the treatment of ILD. One was looking at pirfenidone, which is an anti-inflammatory and an antifibrotic that inhibits production and activity of TGF-beta. There were animal studies that suggested that pirfenidone might be beneficial, and after a number of randomized trials, it was determined that there was a significant slowing of the rate of decline of FEC and an improvement in survival, a decreased risk of mortality in patients who were treated with pirfenidone as compared to placebo. And I won't go over this in detail, but it has been demonstrated now that even in patients who show a decline on pirfenidone, the risk of death is diminished if patients continue on pirfenidone, even in the setting of that decline. And so we have been keeping our patients on, although there are significant side effects associated with pirfenidone treatment, but if patients can tolerate it, we have been keeping patients on, even in that setting. Similarly, nintedanib, which is a competitive inhibitor of the VEGFs and the PDGFs, which reduces proliferation, migration, and survival of fibroblasts and attenuates angiogenesis, which I mentioned to you in the pathophysiology is important. There was a significant benefit for patients who received nintedanib as compared to placebo in terms of slowing down the rate of progression of decline of FEC. And nintedanib was also demonstrated to be effective in preventing acute exacerbations in IPF. So that was all very exciting news in 2015. And as I mentioned to you, there's been a subsequent study looking at patients with non-IPF progressive fibrosing interstitial lung disease. And this population went across the gamut. It could have been hypersensitivity pneumonitis. It could have been autoimmune ILD. They had patients with all sorts of fibrosing interstitial lung disease. And they saw essentially the same slowing in the rate of decline in FVC for patients with those diagnoses who received nintedanib. So we have broadened our horizons a bit in the use of at least nintedanib to treat fibrosing interstitial lung disease. And even more recently, there have been a couple of New England Journal publications demonstrating effective therapies for patients with IPF. One looked at inhaled treprostinil for patients with IPF who had associated pulmonary hypertension. And here it was demonstrated their 6-minute walk distance improved significantly compared to those who received placebo. And even more recently, a phase 2 study, so this has not been studied yet in phase 3, but this phase 2 study looking at a preferential phosphodiesterase inhibitor, which affects both inflammation